So we just learned about upper airway process and structures there. Again, nasopharynx, oropharynx, or pharynx. You also have a hypopharynx, which is back of the throat, pharynx down to your larynx. Larynx is where your vocal cords would be. So anything vocal cords above would be your upper airway. Anything vocal cords down is your lower airway. So looking at the lower airway, and we talked about what was the number one cause of upper airway obstructions? If you said your tongue, you would be correct. So we have maneuvers in place, simple airway maneuvers or airway adjuncts we can do. Basically what we're doing is pulling that tongue off the back of the throat to allow the air to flow. So anybody who snores at night with sleep apnea, so what's happened with sleep apnea is your tongue falls backwards. Your tongue is just relaxed. So anytime you're unconscious, asleep, or whatever, tongue and your soft tissue in your throat relaxes, and then that reduces airflow. So when somebody snores, when snoring occurs, you have as the airway is passing through, passing over that soft tissue, it kind of flutters, creates the snoring sound. So snoring sound or sonorous sounds of breathing is indicative of an upper airway obstruction. So this to note, if you were to see your patient unconscious, snoring respirations, we can conclude they have an upper airway obstruction, so then we would need to intervene. We can do one or two things, is do a proper head tilt chin lift to create a proper opening airway channel. If not, we can use what we call airway adjuncts, which is oropharyngeal airways or nasopharyngeal airways. Oropharyngeal and airways go in the mouth, like a J, that basically just pull the tongue in place where it should be. And then nasopharynx goes through your nose and sits on the back side of your pharynx just before you get to the vocal cords. So those are issues and ways to maintain an upper airway. So what about our lower airway? Any guesses what the number one cause of lower airway obstruction is? So I want you to sit on that for a moment and look at anatomy of the lower airway. So a lower airway includes everything from our vocal cords on down. So if you can see on our presentation model here, you have a hyoid bone. Hyoid bone is the bottom. Or hyoid bone is the only bone that's not connected to any other bone in the body. So hyoid bones are considered, if you have a hyoid fracture, then it's pretty bad off, that not many people with a hyoid fracture survive. And it's not necessarily because you broke the hyoid bone, but it's the forces it took to break the hyoid bone that you probably have other problems, such as cervical fractures or any other multi-system trauma. So we have our hyoid bone. You see our larynx, our trachea, then here's our carina, branches into our right and left main stem bronchus, going down to alveoli. So if you look at a cross section of our airway anatomy, so if you look at this cross section of our trachea, so notice we have our tracheal rings around, tracheal cartilage. Those provide structure and support, also provide some protection. So on the inside is we have soft tissue or muscular layer. So muscular layers of our trachea constantly opens or relaxes. This is an issue with asthma patients. So with asthma patients, you may have what would happen in asthma patients is this tissue may begin to swell. And if it begins to swell, then you will reduce the diameter of the airway and reduce the airway flow. So the smaller the airway is, you're still trying to move the same amount of air, but the smaller the airway is, the higher pitched sound you may have, and that's going to be associated with wheezing. So, and this would also extend down into the bronchioles. So as the soft tissue, the bronchioles inside begin to swell, we would limit the amount of air that's going to the alveoli. So with those conditions, we talk about those more with medical emergencies. Just for anatomical reasons, I want you to understand what we're talking about. So if we reduce the size of the airway, we're going to increase resistance. If you increase resistance, you're going to, and especially with the soft tissue swelling, you're going to cause wheezing sound. And asthma typically has wheezing sounds. There's other airway conditions that can cause obstructions, such as chronic bronchitis, or and those are airway obstructions kind of thing. You have emphysema. Emphysema is more associated with the alveoli problems, more so than the airway problem. It is an airway problem because we're dealing with the alveoli, but as far as obstruction, we're looking at bronchitis, asthma. Another concern would be any upper airway burns or inhalation burns. Not only would you have airway swelling in your pharynx or nose or mouth, you also, if you have somebody inhaled hot steam, then it can burn the lower airways as well. And those may have similar things. It's still going to have the swelling around the soft tissue, and may give us a noticeable wheezing associated with it. So you have audible wheezing. Whenever we look at respiratory, we cover that part of assessment, we have audible wheezing. And then we have, so audible wheezing, you don't need a stethoscope to hear. You are standing next to the patient and hear them wheezing. And then we have not so clear wheezing that you have to have a stethoscope to listen for. So it's also important to understand what we're looking for and what we're listening for. So going back on review, and this was covered in our last section, is ventilation. So what is ventilations? Ventilations is the process of bringing outside air into our lungs, right? We need oxygen that's out and floating around to our alveoli. So that is an active process. So when you say active versus passive, active process requires energy. So this is something you're having to think about, not necessarily think about, but your muscles having to do the work to get oxygen in. Versus a passive process. When you exhale, that's a passive process because it's not requiring any muscle usage in a normal, healthy individual. Patients with COPD, either chronic bronchitis, emphysema, or asthma, they're having to work to get air in because, again, you're taking diameter, a bit exaggeratory, airway diameter that big down to that big, and you're trying to move the same amount of air because our oxygen demand hasn't changed. So our oxygen demand hasn't changed, so we still need the amount of air in. The problem is you have problems getting it in, so it takes a lot more energy to get the air outside floating around into our lungs. So if you have somebody with asthma or COPD, those are two conditions that if they're having an exacerbation or a flare-up of that, they're having to use a lot of energy to get air in. And then what would normally be a passive process, that becomes an active process for them too, because they're having to forcefully breathe air in and then forcefully get air out. So what would be a passive process now is an active process, and anytime you're using that much energy, you're going to become tired. So let's review what's our process, right? So we have our chemoreceptors, baroreceptors. It's measuring our pH, measuring our carbon dioxide levels, it's measuring oxygen levels. It's inferred through our brainstem. Our brainstem then sends that information through the phrenic nerve down to our diaphragm and intercostal muscles. So when we take a breath, our intercostal muscles contract, pull outwards, diaphragm contracts, pulls downward, creates negative pressure in our chest. Negative pressure in our chest is like a vacuum cleaner, pulls air in. So that's the active process of ventilating. When we exhale, that's a passive process, and all you do is relax. When you relax, the pressure inside of our chest, because now we're chest is slowly going back to normal, that creates a higher pressure. So we have a higher pressure than atmospheric pressure, so then air goes out. When we inhale, our muscles contract, diaphragm pulls downward, chest opens up, creates negative pressure. Negative pressure then allows air to pull in. So it's basically you're sucking air in through the process of having negative pressure. So when we're looking at that, that's the mechanics of ventilation. And you think about everything that needs to be in place, right? We need an intact brain function, we need an intact brain stem, we need intact nerves, need intact muscles, need an intact chest wall or pleural cavity that's going to allow that negative pressure, that's going to allow the air in, and it also need that higher pressure when we exhale to allow air out. So if we have a problem with any one of those, so if we have a problem with airway obstruction, we have a problem with nervous system function, we have a problem with the muscular function, then it's going to cause problems with ventilation. So, and that's just in ventilation. So now let's look at respirations. Again, what was ventilations? So ventilations is the mechanical process of bringing air into our lungs. Respirations occur at the cellular level. So, and I say it like this, is no matter how much you ventilate somebody, you cannot make them respirate. So we can ventilate and provide artificial ventilations all day long, but we can't do anything with the respiration side of things. Now, we can do everything we can to make it conducive for respiration to occur, as far as getting adequate oxygen there, make sure we have adequate tidal volume while we're ventilating, those kind of things, but we can't do anything at the cellular level. Now, we can make sure we have good perfusion, good oxygen levels, etc., but we can't change what happens at the cellular level. Now, again, we can make sure the factors are present for respiration to adequately occur, but there's nothing we can do through ventilation to allow respirations to occur. I know it's a little bit confusing, but ventilation is the mechanical process of moving air in and out. Respirations is a gas exchange at the cellular level.